So welcome everyone. My name is David Galloway. It's my real privilege on behalf of our duty of care to welcome you to this event this evening. It's a little bit of deja vu for me because I used to operate in this particular room quite a bit. At one time I was president of this college, and in fact this room that you're sitting in right now is a kind of interesting room from the point of view of medical controversy. And here we are tonight facing something which for our nation, I think, is of considerable significance. And I think the reason for that will become even more colourful when you hear from our speaker this evening. And I'll say a little bit about Leonie, Herx, our speaker from Canada, shortly. But this room is known now as the Princess Alexandra room, and you're very welcome here. At one time, this was a dwelling house, and this would have been a rather grand drawing room. The college moved here in 1862. And at that time, there was a young, relatively young professor of surgery, Regius professor of surgery, no less, in the city, who was well known and became particularly well known, ultimately became the first medical lord of the realm. And soon after the event, which I'm going to describe to you, which took place in this very room, he became Sir Joseph Lister. And Lister, for those of you who know anything about medical history, will realize was really at the forefront of a particular controversy, which again was a life and death issue in his day. And he presented in this very room to the college. This was the college hall at the time, before any of the buildings at the back had all been erected, the buildings that you'll see as you go down the stairs later on. And on the 17th of April, 1868, Lister was here with a full room comprising the members of the Medico-Chirurgical Society of Glasgow. Now, they used to meet in a tavern down in town somewhere, and all sorts of goings on, which can't be repeated in polite company, have been recorded. But on that particular occasion, he was presenting something very controversial. It was what he described as the atmospheric germ theory of putrefaction. And when you read the minute of that particular meeting, I don't know who the minute taker was, but he was clearly unsympathetic to the message he was hearing. It is just riven with cynicism and skepticism that Mr. Lister supposed that there might have been particles in the air that were responsible for surgical sepsis. And of course, Lister was going against the grain, but Lister was right, as it turns out. And you know, there's a sense in which when we consider a topic such as the topic before us this evening, I get the impression that, at least as far as the public consciousness is concerned, not necessarily the medical consciousness, but I reckon that we are kind of going against the grain to some extent. But I think the message which is being supported and pushed by this particular group, which is the kind of medical arm of Care Not Killing, a campaign group resisting a change in the law to potentially introduce assisted suicide in this country, I think you're going to find that this group are also right. Anyway, I'm going to let the data speak for itself, but I just thought that was an interesting little parallel between what was going on in the 1860s, 155 plus years ago, and what's going on in 2023. So this evening, we're going to be dealing with this issue. I don't know whether you noticed in the news today. If not today, then you'll certainly find it in tomorrow's press, where the Association of Palliative Care Physicians in Great Britain and Ireland had been carrying out a survey, which they've just recently published. And in that survey, it is very clear. 3 take-home messages I took from it. I mean, there are many more details that we could cover on another occasion. But number one, there was almost uniform resistance amongst palliative care professionals to the idea of changing the law and introducing assisted suicide. Number 2, take-home message was this: real concern amongst that group that to change the law like that would considerably devalue and underrate the provision of palliative care. And you're going to hear a lot about safeguards. That group of physicians believe that the so-called safeguards are nothing of the kind. And it's important that you file that away and register that with the kind of information that you're going to hear this evening. Our speaker this evening, Professor Leonie Herx, who's standing by the door there, Welcome, Leonie. I think this is your first visit here. I hope not your last. Well, there we go. We laid on the sunshine for her this evening. Leonie has a background in family medicine and palliative care. So she was part of an MD, PhD academic program at the University of Calgary, practiced there in both adult and pediatric palliative care for some 10 years. And she's been an advocate for really developing that specialty in Canada. You know, there are only, I think only 3 colleges of physicians and surgeons, truly interdisciplinary colleges in the world. One is in Canada, one is in Pakistan, and you're sitting in the other one right now. And it's interesting to me that one of the things that Leonie has been doing has been advancing the case for good quality palliative care in Canada. She's done that through her profession, through training, and working on professional development for younger colleagues. But she's also been involved in the College of Physicians and Surgeons of Canada and has co-founded that specialty of palliative care in Canada and hopes to see that really pick up speed and roll out. And she's also been involved in training and assessment for specialists in training in that specialty. She's also been president of the Canadian Society of Palliative Care Physicians. So we have before us this evening someone who really knows her brief pretty well and has this amazing opportunity now to help us learn from the Canadian experience. Canada introduced what they call MAiD, Medical Assistance in Dying, in 2016. Within the first year or so, there were 1,018 people availed themselves of that service and died with medical assistance. The last year for which we have any figures, and you may have more up-to-date figures than I've seen, 2021, there were over 10,000. And as happens in just about every country or jurisdiction where a change in the law like this happens, indications begin to relax, things begin to change. It's no longer just those who are terminally ill. Those who are keen to advance this idea push at the door. And before you know it, it's not just terminally ill people, it's chronically ill people. It's not just older people, it's sometimes children. And in some jurisdictions, it's not just people who are ill at all, but people who want to indicate that their lives are complete and seek medical assistance in dying. These are chilling statistics and things that we need to be very aware of. I was just reflecting on the fact that if you look at it carefully, our Parliament takes advice, expert advice on a whole range of topics. They did it on conversion therapy. They did it on the gender recognition. Remember that one bill that came before the Parliament? They've done it on assisted suicide. Let's use our terms carefully and properly. It's assisted suicide, not assisted dying. Palliative care might be best represented as assisted dying. That's just by the way. Nevertheless, what has been very clear is that the advice that the Parliament has taken has been uniformly and almost completely, entirely one-sided, polarized and partisan. The same thing happened with the medical advisory group, so-called, that advised the MSPs on the issues that you're going to discuss here this evening. ODOC have just produced a very interesting pushback to that, which I'm sure you'll be able to see on their website. If not now, then very soon. But I think the time has come to listen to the lessons learned from Canada. Leonie, would you come and give us the benefit of your experience? Let's welcome her to Glasgow, folks.
Thank you so much for having me and for that generous introduction and for the invitation to come and be here. I think this topic is so critical because it, as you'll see, I hope I can convey, it's fundamentally changed palliative care, but also the practice of medicine in Canada. And I think Canadians are a bit taken aback as our medical professionals how we got here so quickly in a sense. So I'm going to walk you through how things have unfolded in Canada and then really spend more time talking about how this is impacting the practice of medicine and palliative care. And then I want to leave lots of time for us to discuss, because I do think, goodness, the richness of will be in our dialogue together. And hopefully I can provide some context for you to think about how you might approach this with some national advocacy in Scotland. So I'm going to start with some things that David's already covered, but a bit of a definition, talk about the distinction between what we'll call MAiD and palliative care, the history and progression of our Canadian legislation, talk a little bit about eligibility, safeguards and oversight, some statistics, and then really spend the focus of the talk on the impacts. So death intentionally caused by lethal drugs in Canada is called medical assistance in dying. It includes both assisted suicide and euthanasia. And the difference between the two is whether the person self-administers the lethal drugs, which is assisted suicide, or whether a clinician, or in Canada, a doctor or a nurse practitioner, directly administers the lethal dose of drugs. And in Canada, it's usually via the intravenous route that the doctor does that. And interestingly, when both are available, it seems the easy option is euthanasia, and almost all the cases of MAiD in Canada are actually euthanasia. So last year, of the 10,000 cases that David referred to of MAiD deaths, less than 7 were assisted suicide. And I think one of the big things that I try to convey, especially when I do public lectures on this, is that euthanasia and assisted suicide are not the same thing as discontinuing life-prolonging treatment or forgoing futile medical treatment. And a lot of people do think that that's the case. They think, oh, if I stop my dialysis, that's medical assistance in dying. And I think it's really important that everyone's clear that that is not, that is a right every person has to decide on what treatments are appropriate for them in the context of their illness, and in conjunction with their physicians, what will best help them meet their needs and their goals. And it's also not palliative care. And I'm going to talk a little bit about that now, because in Canada, it was expected that when this was legalized, it was framed, as we'll talk about, for people with reasonably foreseeable death, very similar to the consultation happening in Scotland. And so people had this sense from the media portrayals and the way it was advocated for publicly to become legalized, that it was for people at the very end of life with poorly controlled pain from advanced cancer, for example, who had short months left to live. And so they thought, well, that's end of life care. That's palliative care. And so there was this sense from the medical community, not just the public, that this was just what palliative care did. And there's certainly a lot of old myths and stigmatization around palliative care, that we give large doses of morphine and we shorten people's lives. And that's actually one of the main barriers to early involvement of palliative care by our oncology specialists, for example. There's lots of studies looking at what is the barrier to having palliative care involved early on from time of diagnosis of a serious illness, because palliative care focuses on helping people live well until they die or until they recover from their illness. So some people have progressive life-limiting illness, and some people have a serious life-threatening illness that they go on to have a cure from. And we can be involved in both alongside disease-modifying and life-prolonging therapy. And in fact, studies robustly show that the earlier palliative care is applied in a person's serious illness, the better quality of life a person has, less caregiver distress, reduces healthcare costs, and surprisingly, people live longer. Palliative care does not hasten death or shorten life, and it is internationally recognized as a practice distinct from medical assistance in dying. And in Canada, it was actually made part of the legal safeguards for MAiD. So as part of the discourse around legalizing this, it was said that persons should have access to palliative care to make sure they don't have uncontrolled suffering. And we'll talk a little bit about very poor access to palliative care that we have in Canada. But it was just this expectation that this is what we would do. We already do that. And so there was this intensification of fears around what palliative care does, intensified fears around what ordinary dying and death look like as part of this advocacy campaign for why we needed legalized assisted death, because people have horrible deaths otherwise. Most people have very comfortable deaths, and we can provide palliative care for those that have more complex symptoms, specialist palliative care for the most complex symptoms. And so there's no reason for a person to have uncontrolled suffering. So the Canadian legislation became into effect in 2016, and they the court ruling that prompted the legislation called it assisted death or physician assisted death, but the Canadian government wanted to call it medical assistance in dying. And we as a palliative care community did speak out very loud and clear and advocated that that was very confusing language because of the reasons David said earlier, that as part of palliative care, we provide care at the end of life as one part of what we do, and provide assistance to people who are dying. And so we were very worried that this was going to be conflated with palliative care for all those reasons we just talked about. But the government was very insistent that this would what it would be called, and they didn't want any reference to suicide or euthanasia because if that would be too harsh in the implications of the connotation with suicide, which I'm going to just park there and come back to later. But what happened very quickly is that within a few months of the legislation taking effect, we had court cases brought forward where people said, well, I have intolerable suffering as well from my osteoarthritis, and I'm being discriminated against because I don't have a foreseeable death from my condition. I want a right to have an assisted death by a doctor as well. And judges started ruling in favor of those cases. So, and actually on the next slide, there's an example of this patient AB, who was this 77-year-old with osteoarthritis, and the judge ruled that it was not necessary to determine the prognosis of a patient to be considered to have a reasonably foreseeable death. And then what happened then is that MAiD providers, so the euthanasia providers, and it's easier just to say MAiD, although I don't like to use euphemisms, but just for today's talk, if that's okay, I might say MAiD. Then they went back and they said, well, I'm actually going to approve cases that I didn't approve before because now I feel comfortable that I'm not going to be criminally prosecuted if I go ahead and change the way the legislation was being interpreted. So this example of this woman on the right, her name is Robin Morrow. She had Parkinson's disease and she wanted to have an assisted death. She was early in her illness, and the MAiD provider thought she had at least 5 years left to live, and had originally denied her access to MAiD. And then after this court ruling, she then did a media interview and said, I'm going to reverse this decision, and helped other MAiD providers understand how they could use these cases to progressively interpret the legislation and feel that they wouldn't be prosecuted. I'm sorry if there's a bit of a ring. So that's really important because this is something that I would say you would expect to see here as well, because once you make death a medical treatment and it's for intolerable suffering that's subjective to the person, then any type of suffering legally should, person would have a right to say, well, why is my suffering less than this person's suffering? And we have seen that over and over again in the Canadian courts. So I'll just go back a second. So then there was another landmark case from two persons with disabilities. One had cerebral palsy and one had post-polio syndromes. They had physical kind of ongoing permanent disabilities from injuries earlier in childhood or infections earlier in childhood. And they said that it was unconstitutional against their rights, discriminatory against them, to say that they have to have a reasonably foreseeable death to be eligible for MAiD. And the judge ruled in their favor and said it was discriminatory and they should have a right to access it as well. So then the Canadian government amended the legislation to remove the requirement for a reasonably foreseeable death. And in 2021, opened up the legislation formally to persons with any type of disability, chronic illness, and mental illness would be allowed in 2 years, which comes into effect in March 2023. And that's mental illness as a sole diagnosis. So right now you can actually have a mental illness as the main reason for your suffering, your intolerable suffering, but you have another qualifying physical condition or a disability that allows you to access MAiD, and I'll give you some examples. But what they also did, they went beyond what the court ruling was to say the reasonably foreseeable death criterion was discriminatory, and they removed safeguards. And we're going to go over that because the safeguards, some of them weren't being followed to begin with, and they were being seen as barriers to accessing MAiD. But then, so then the government took opportunity during that revision of the legislation and removed quite a few of the things that were put in place to help protect vulnerable people. And now there's a new committee in our parliament whose report is due next month in February 2023, that's been looking at the next steps in the progression of expansion that the government has indicated they plan to do, to look at expanding to children deemed capable to consent to medical treatment and advanced directives for MAiD. So at some point in the future, if you have dementia or have a type, some type of suffering that you'll find intolerable, you can put it in an advanced directive and say, I want someone to end my life. And legally, you can see the argument for why it would be expanded to children. So they're proposing, the lobby groups in Canada are proposing children as young as 12, because there's this concept of mature minors. I'm not sure if you have that concept here, but it's children who are able to make their own medical treatment decisions. And if euthanasia MAiD is considered a medical treatment, then it's actually, you can't actually say they can make their own decisions about whether to have chemotherapy for their leukemia, but they can't decide about MAiD. And so that's the legal argument being put forward, that it's a medical treatment, it's a medical treatment. They have a legal right to be able to do that. And so in other countries like Belgium and the Netherlands, they have advanced to euthanasia for children, actually even beyond mature minors. So I do expect that we are going to get there in Canada sometime soon. We talked about that. So that 2021 expanded legislation created two tracks of eligibility. Track one, which is for people whose death is reasonably foreseeable, which was already determined by the courts that there was no prognosis required, and MAiD providers were already ending people's lives who had many, many years left to live. So it wasn't people already who were just in those last months of life who we had kind of been led to believe this was who it was for. And then they removed the existing safeguards for that, which we'll go over. And then track two for people whose death is not reasonably foreseeable. And they added a 90-day assessment period for when a person makes that request until they can be eligible for MAiD, which can be waived if the person's going to lose capacity or is at risk of imminent death. So there are ways that those can be removed. But they also said that one of those assessors must have expertise in the underlying condition or consult with someone who does. But it doesn't have to be a specialist, and it's typically the MAiD providers have indicated that they usually feel they have the expertise to understand, and they can phone a consultant, and the consultant isn't required to see the person. So they just have to kind of make sure they've reviewed with a consultant, but the consultant doesn't need to know the person. So eligibility for euthanasia now includes any type of chronic illness. I just list some examples here because I think it shocks some people to think, what, you can get euthanasia for fibromyalgia or chronic pain, diabetes? Yes, and the wait list to see specialists if you have difficult symptoms from these things like chronic pain, the wait list in Canada is about 18 months, in some places 2 years to see a specialist. So the 90-day assessment period is hardly enough time to even see a general practitioner, never mind a specialist. But if you have such difficult to control symptoms that you think you'd be better off dead, 90 days is just not enough. Psychiatry in particular, some people wait 2 years to see a specialist in psychiatry. And the definition of disability is very broad. It includes intellectual, cognitive, learning disabilities, dyslexia. We've had people receive euthanasia for hearing impairment, visual loss. What's interesting is they describe in the legislation that it's anything that disability is anything that hinders a person's full and equal participation in society. But nowhere is it mandated by the government that we provide the supports to help people live to their abilities and flourish. So we have a right to, it's not really a right, but it's presented as, universal access to a right to die, but we don't have supports to help people live and flourish with their disabilities. And I've talked about the mental illness piece. So currently, the government has indicated, after quite a lot of backlash from recent stories in the media of patients who've shared, they've actually had their stories shared after they've died, or their families have shared their stories. That the government has said, well, we might temporarily delay when mental illness as a sole condition will begin, but they haven't yet submitted legislation to amend that. So as of right now, it's still set for March 2023. And I think this is really important because this is what I heard when I was in Jersey. This is what I'm hearing in Scotland, that this is an exceptional measure for exceptional cases. This is like only for people whose symptoms can't be controlled in any other way. This is, we were promised this was really about improving access to palliative care. This would strengthen the development of palliative care in Canada. And there is this concept in the Supreme Court discourse on this about this Canadian exceptionalism, that we would have these strict set of safeguards and this narrow focus, and we would not be like Belgium and the Netherlands, who've had this runaway train and are providing euthanasia for anyone. And I'm here to tell you today, Canada's MAiD regime is more permissive than the Netherlands and Belgium. So we quite missed the mark on what we were initially promised. So these are some of the statistics David's already shared. So since June 2016 to the end of 2021, which is the end of the last reporting period, we don't yet have the statistics for 2022. There's been almost 32,000 euthanasia deaths. Each year it's increased steadily, as you can see in this graph, between about 25 to 35%. And right now it accounts for just over, as of end of 2021, about 3.3% of all deaths, with significant regional variation. So it's almost 5% of all death causes in Quebec, in British Columbia, and in some areas of Vancouver Island, it's over 8%. What I find fascinating is that, again, and I'll come back to this about medical practice, is that in any other area of medicine, let's say obstetrics, and you were having C-sections with this variability in rates. If you had a region that had over, double the C-section rates of another region, you'd be investigating like what's happening here, that this is, not within a keeping of a standard of practice. But the same type of investigation is not happening in euthanasia. The reasons people request MAiD in Canada are consistent with international data, and that it is primarily psychological and emotional existential suffering. It is not uncontrolled physical symptoms like the media and the lobby groups portray. These are people who are afraid of being a burden to other people. They feel unable to enjoy life. They want control over their death, and they do have a fear of future pain and suffering. And so I think that's really important, because it's often people who feel demoralized, they had a change in their role, it's people who are depressed, people who are lonely and isolated, and the way our society has this pressure that you're valued for what you do, not who you are as a person. And that has implications for, I think, the way persons with disabilities are experiencing the Canadian healthcare system right now, since euthanasia, not just since euthanasia, but so I want to talk a little bit about that too. This was the system of safeguards that we were assured was going to prevent errors and protect vulnerable persons from wrongful deaths. And, when the Supreme Court tasked the Canadian government with putting in legislation that would have a robust system of safeguards with monitoring, as I said, to prevent premature death. So I won't go into all the details. You can see the pieces there, but what happened over time is these safeguards were dismantled and eroded. So with the new legislation in 2021, they removed many of these safeguards, which there was evidence already some of them weren't being followed. It was very difficult to find two independent witnesses, and it was often the volunteers from the lobby group Dying with Dignity who would come to the hospital and witness the consent. And the original intention of the witnesses was to verify that people weren't being pressured into choosing MAiD, and they were choosing it free and voluntarily, and they were witnesses to that effect. But nobody has training in detecting coercion. In fact, it's very difficult. And then I wonder how objective it is if someone's coming from a lobby group to volunteers who have a very biased view about what this is. So I don't know, but they changed it from 2 witnesses to 1. That witness can now be a paid healthcare worker. There was a requirement for people with a reason for foreseeable death to have capacity and had to reconsent to having the lethal drugs at the time of the administration. They removed that because it often wasn't being followed anyway. There were already clauses in place to allow exceptions if a person was going to lose capacity or die before the 10-day reflection period. But it was being waived for reasons other than that. And they felt that it was a barrier that we shouldn't make patients wait 10 days. If they've already decided they wanted MAiD, they should just be able to get it. So that was removed. So now we have same-day death in Canada. So you can request MAiD and get it on the same day. And that does happen. And there's a bill that's in the Canadian Senate right now that's passed first reading to extend this waiver of final consent, is what it's called. So you don't have to have capacity, to the track 2 patients. So, and you can see why, again, legally, that it's discriminatory to say, well, if you have a chronic illness or disability, you have to have a reflection period, but you don't if you have a reasonably foreseeable death, given that people often have many years in the category of reasonably foreseeable death. Then we've already talked about the removal of the eligibility criteria, and then the independent nature of the assessors and in the truly nature of informed consent have both been called into serious question. And one of the things around consent is that, are people truly having other options accessible to them? Because what the legislation requires is that you just receive information, what your other options are. But if you're at a point where your suffering is so intolerable that you think your life is better over and you're better off dead, it's very difficult at that point to say, just wait, we need to give you palliative care for a few weeks. And there's just and it's not even accessible in some regions, right? So whether they've had home care or disability supports, like it's not really informed consent if it's not been tried or accessible. And often it's sometimes now MAiD is the first thing a person receives because they've not had their other illnesses treated. So there's a question in the legal community of what is considered informed consent. And many of us are concerned that people actually don't know what palliative care has to offer. If all that you're told about palliative care is what the MAiD provider tells you, and they don't understand that what palliative care is, and they think it's giving large doses of morphine, then it's challenging. And many of the assessors come from a small community of providers and their colleagues, and they see each other's reports. And so, and they do telephone assessments. And other virtual assessments, and they might not even know the patient. So there's some concern about that independence. Lots of good evidence to show that safeguards were not being followed by clinicians, and I've referred to some of it. I'll also mention that there's no mandatory training or certification to be a MAiD provider. Any physician or nurse practitioner can decide they're going to do it and start offering it. There's no system of oversight or real-time monitoring. So because it's a medical treatment, it's left to the subjective oversight of the MAiD provider themselves. And they have to self-report anything around the MAiD event through an automated portal. And it's more of a system of checkboxes. So did this person have access to palliative care, yes or no? And if you check off no, but nothing happens, there's no stop mechanism. So it would only be if the individual MAiD provider said, wait a minute, here we have to do something differently. But that hasn't been happening. And the data is submitted into a central portal that's retrospectively reviewed a year later, not at an individual patient level. So there's nothing in place to kind of intervene if there's something awry. And there are many examples in my practice of, as I've been a medical director in different roles, of patients who my team has felt did not have capacity. This is before the law was changed that you could enter into an agreement where you would waive that final consent, but we didn't feel they had capacity for the initial consent. And I'm an expert in delirium. Like I, understand when people are confused and aren't able to understand their options. And if we raise concerns about that, we're seen as trying to obstruct access to MAiD, or we're against MAiD, as opposed to advocating for patient safety. And nothing has been done about it. I've even written in charts and called the MAiD team and said, this person, in my opinion, doesn't have capacity. I would recommend a full capacity assessment by psychiatry, but there's no oversight to do anything differently unless that individual is as concerned as I am. There have been annual compliance concerns documented by all of these professional bodies, including the Correctional Investigator of Canada. And I mentioned that because, as we'll talk about later, people most impacted by this legislation at risk of wrongful death are the people on the margins of society who don't have access to the supports they need to live full lives. And MAiD is being provided in prisons. And we have people who can't get parole and have life sentences in prison who are now opting for MAiD to get out of prison, or because they can't get the care they need in prison. So it's very ethically very challenging. And there's just a quote there from one of the Office of the Chief Coroner of Ontario that talks about compliance concerns with both the criminal code and regulatory body policy, some of which have recurred over time. So very worrying But interestingly, no doctors have ever been charged. Our government has done its own report to look at how much the cost would be of expanding the legislation under the 2021 Beyond to Chronic Illness and Disability. And the Parliamentary Budget Office reported that it would save healthcare costs over 150 million per year based on 1,200 additional MAiD deaths per year. But I've already showed you that the MAiD deaths are going up about 30 to 35% each year. So that's a significant underestimate. And that's on top of what an early study showed that there would be cost savings from the initial legislation between 35 to 140 million per year based on a 1% MAiD death rate. Now we're already at 3.3%. So I think it is significant to understand in a strapped system of, healthcare resources are under, there's human resources are underfunded, services are underfunded, and now we have something that saves a lot of money. And I worry that that has implications for promoting and funding particular systems of care. And I'll talk about that when we get to palliative care. We are in fact seeing reports from Canadians who have had MAiD recommended to them because the cost of their care is so high, or they have been perceived to have a poor quality of life because of a disability, for example. So these are just some examples from Canadian media, and this is just a few. There are many more, and if you're interested, there's a good website now that's collecting all the stories of these Canadians. So Roger Foley on the right, he recorded health administrators, not even a doctor, at the hospital, suggesting that he should consider euthanasia because his care couldn't be provided outside the hospital, and he'd been living in the hospital for over a year. And he reports that he had euthanasia offered to him repeatedly when he was not expressing any desire to die. He very much wants to live, and felt very discriminated against. The family on the left, this daughter had a developmental disability, and she came into the hospital with a chest infection. And it was suggested to her by the doctor, to both the mother and then in front of the child who's in her, I think she was 19, with a developmental disability, that it would be, she should consider euthanasia would be better for her. And, I know we saw during COVID, right, there is decisions made on behalf of persons with disabilities that they weren't consulted about. We've all heard about the stories of do not resuscitate orders, kind of put blanket statements out, and Canadians with disabilities are very worried about coming to the healthcare system now. The fact that disability alone enables you to be eligible to be put to death is just reinforcing for them that their lives have no value when they're already experienced significant systemic barriers to accessing healthcare and social care supports. In fact, the Canadian Federal Minister for Disability Inclusion herself testified to the Canadian Parliament looking at MAiD expansion and said that in some places in Canada, it's easier to get access to MAiD than it is to get a wheelchair. So our own government is admitting that we don't have the resources in place for some Canadians with disabilities to live, but they're being offered death very often. And so there's this concept now that our disability community is putting forward about the need for safe physicians and safe spaces where people won't offer them death. And they're getting tattoos on their chest that say, do not talk to me about MAiD, because they're worried about coming into the hospital and it being suggested to them, and they may be in a vulnerable position in a period of depression, for example, where they might take it. And that has happened. I've seen patients who have full-blown depression and there's no requirement for the depression to be treated. And they've had euthanasia because of their depression, but they were eligible because of some other condition. I had a woman with congestive heart failure who came in with a new diagnosis, but in a period of depression, refused to take psychiatry's recommendations, didn't even want to talk to me about managing her breathlessness, and died the next day. So it was very troubling for the cardiologist and myself. And then we have examples of social care workers, in this case, Veterans Affairs workers, so not even healthcare professionals, offering euthanasia to Canadian veterans who have PTSD and are sometimes suicidal. Again, it wasn't brought up by, these weren't veterans who were asking to die, but it was suggested that they didn't have to kill themselves. They could have a doctor do it for them. And there's an inquiry at a federal level now looking at how many of these, and it was multiple people. But so these are just some examples of kind of what we're experiencing now in Canada. We also see lots of Canadians requesting MAiD due to lack of access to adequate care, poor living conditions, because they can't afford housing. There's been a couple of women, there's a story on the bottom here, that have chemical sensitivities and couldn't find housing and tried and had actually their own physician advocating for them and writing letters, and they couldn't get housing, and they felt they had no other choice but to die and got euthanasia. People that had no resources in their local communities and would have had to move 5 hours away to access the resources they needed to live, and didn't want to leave their family to be put in a residential care home so far away from their family. So they got euthanasia because they couldn't bear to be apart in their last years of life from their family. This woman with the sunglasses, she was a very fit, healthy 90-year-old woman who very social, loved to play games, and got very depressed during a COVID lockdown. And she was in her room, they weren't allowed to leave their room. It was for many weeks at a time. And she was so lonely and depressed that when they said there was going to be another lockdown, she said, I can't possibly live through that again. And she requested euthanasia and received it to avoid another COVID lockdown. There are people who can't afford a good quality long-term care home and are living in poor situations in state-funded long-term care homes who have requested MAiD and got it because of the poor care. And there's a growing number of families now sharing their stories about this. And again, it's not at all what we were told at the beginning that euthanasia was for, that it was going to be for these hard cases, at the end of life of advanced cancer. But these are the people who we see who actually want to live, but aren't given the supports to do so, who are getting premature deaths. So MAiD really has been rapidly normalized as the standard medical therapy. We've had this incremental desensitization over the last 5 or 6 years. It's stated that this is just routine care, and the MAiD advocates are promoting and created a guidance document that's now being advanced as if this is what should be the standard of care, that we should, as physicians, we have a duty to inform all potentially eligible persons about MAiD. That's all of my patients. That's pretty much any adult 18 and over at this point, soon probably to be children who can consent. And imagine like coming and you getting this terrible diagnosis, and it's very, people face despair and anguish when they get bad news, like trying to make sense of how could I possibly have breast cancer. Even if it ends up being a chronic illness, it's still devastating to find out that you have rheumatoid arthritis, right? And people just think like, how am I going to manage this? And then you're offered euthanasia as one of the options. It's just unthinkable. And we have many patients who have told me that they only requested MAiD because a trusted doctor recommended it to them. So I've had patients tell me, I requested MAiD because my doctor said it would be a good option for me, or I would be a good candidate. And it is being brought up routinely now in healthcare in Canada, as if it's just like getting antibiotics. Even in acute medical situations where someone comes into an emergency room in a crisis, it's being presented as one of the options. So it's very difficult, and the regulatory colleges, I know here you have the General Medical Council, we have provincial colleges, and then we have a federal medical regulatory authority that kind of gives guidance to each of the provincial colleges. They testified to the Parliament during this expanded MAiD that they do think doctors should have a duty to inform all potentially eligible patients as part of informed consent. And so we're getting concerned that that's actually going to be enacted in the updates to the physician regulations at the provincial level. So there's quite a number of us who are very worried about that we might have to leave the medical profession or move to another country. I certainly won't be able to practice medicine in Canada if I have to suggest my patients are better off dead, when MAiD is sometimes the only treatment treatment, quote unquote, a person has had, because they only need to be informed of their options. They don't need to have tried anything in an evidence-based way that we usually do for medicine. It's also being promoted as a source of organ donations. And I worry about that because although it's supposed to only be brought up once a person has decided about MAiD, it's very much talked about in the public sphere, and there's articles in the papers often. There was one last week about how Canada is the source of 50% of the world's organs after euthanasia, and it's a growing source of organs, and those are not cancer patients. You can't donate your organs after cancer except for your cornea. And so as we expand to mental illness as a sole diagnosis, that's going to become an even larger source of organs. And so people know this, and patients have said that they want to be able to leave a legacy and make a difference for other people by donating their organs. And I worry that there might be some internal pressure that people experience when they feel their lives are a burden and their lives aren't worth living, but here I can help many other people. And I don't think we've studied or have the data to reassure us that that's not influencing pressure on people. MAiD and palliative care continue to be conflated, even though we've been very clear, and every international palliative care organization has confirmed that they're distinct. And I don't know why that is, if it's to legitimize it or if it's because it's been funded out of palliative care resources, but because it was put into end-of-life care program, which was palliative and end-of-life care, because that's what it was thought to be in the beginning. You have this new service that you have to implement across your health system, but no net new funding, right, to roll this out. You have to take it from an existing budget. So it came out of, in many places, the palliative care budget, including administrators and managers who are tasked with coordinating this. Instead of coordinating and managing palliative care, they're spending more and more time doing MAiD. And in fact, we've had nurses leave the palliative care roles because they're spending all of their time coordinating and dealing with MAiD, which is opposite to the philosophy of palliative care, but also taking them away from their vocation. People really going to their, your areas of medicine because you feel passionate about making a difference for people, whether it's palliative care or respirology or critical care. And if you can't do your job, it's very difficult for people to stay. And we've been mandated in many places to use our hospice beds for the sole purposes of administering MAiD. So again, I think something for Scotland to be aware of, and it's in palliative care units as well. And there's been threat that funding would be removed, public funding would be removed if you're not providing MAiD in your units and your healthcare facilities. So we've this hospice on the right, the Delta Hospice, the Irene Thomas Hospice, which was also called the Delta Hospice, actually had its funding pulled and they had to close because they didn't want to provide MAiD on site when they had a very good process in place. The hospital is 2 minutes away. No issues with transferring patients to the hospital to receive MAiD if they wanted it there. And I think like nobody cries wolf when we admit patients in their last hours of life. Often people come to hospice way too late, right? Because people think palliative care is like about imminently dying. So it's very common that we admit patients in the last days of life or even hours of life. And nobody gets upset that we transfer patients then. But there's this big uproar that if you transfer someone out of hospice, you are causing them undue harm. So it's a very interesting dynamic. And in palliative care, we've really seen this change in an expression of a desire to die. So as I've said, like when you are faced with a new reality of a devastating diagnosis, you can feel despair and you're not sure how to go on or how to face this. And that usually we come alongside someone and we look at what's causing the suffering, how we can help, what's important to them, reframe hope for them and help them figure out a way to get through this. And most people's desire to die goes away in about 10 to 14 days. But now any expression of a desire to die, like I just can't go on like this, is interpreted as a MAiD request. So the teams are then just calling the MAiD team who comes, and most often it's a reasonably foreseeable death, because there's not very many conditions where your death isn't reasonably foreseeable. And I've already told you it can be many years and 10, 12 years, but you will eventually die from your disease. That is considered a reasonably foreseeable death. So people get MAiD on that same day. So you can be in a period of despair and not given the time to actually reflect. And maybe they would have changed their minds. So that's a very difficult thing for us as well. Access to palliative care, like in Scotland, is not great. We've got a long way to go. Less than 50% have access to some kind of palliative care of unknown quality, and only half of that have access to specialist care to address those more complex issues. And you have lower access to palliative care if you're poor, Indigenous, homeless, incarcerated, or live in a rural area, for example. And I'm sure it's very similar here. And so what's going on with people who are getting MAiD, and what do we know about palliative care? Well, the statistics aren't very helpful, and the way that they're being asked, there's definitely some bias in it because it's, again, self-reporting by MAiD providers. But even with that bias, you can still see that, you know, about 40% had little to no palliative care, either none at all, or palliative care for less than 2 weeks, which it could have even been just a one-time visit by a social worker who talked to them about goals of care. There's just no way that, there's no details that you can tell from this. And this is consistent with another study by a colleague, Camille Monroe, who did a study in Ottawa and looked at how many people who got MAiD also had palliative care involved, and 40% had no palliative care at all. So there is definitely a lack of access to palliative care, and I do worry that that is driving some of the requests for MAiD, although the government tries to reassure us that that's not the case. I think I've already talked about most of this, but we've had not only nurses and social workers leaving the job, but physicians are experiencing a lot of moral distress because we can't do our job. People often don't want to talk to us because they're worried we may prevent them from getting MAiD or try to talk them out of it. Like, I just want to take care of patients regardless of their choice, whether they get MAiD or not. I want to let them know what I have to offer. But like that person I told you with congestive heart failure, she didn't want to talk to me because she'd made up her mind and didn't want to be talked out of it. Also because we're being forced to participate and facilitate MAiD. So if I'm not willing to provide MAiD for my patients and they ask for it, I have to find someone who will do it for them. And because there's such a shortage of doctors who are doing MAiD, and an increasing proportion of people who are getting it, as you've seen, the demand for it is going up. Now, some hospital systems and regions are mandating that doctors do the first MAiD assessments for eligibility, which is active participation in approving someone for euthanasia. So some hospitals, as part of privileging, will say you can work here but you, as an MRP, the most responsible physician, you must do the eligibility assessments. And that is a very difficult place to be if you don't think that's in that person's best interest, because you are proving someone to become dead. So it's very distressing for lots of doctors. I've already talked about, we have decreased access to specialist palliative care beds because they're being used just for MAiD. We do see patients requesting MAiD because it's been suggested by a doctor, and we've seen worsening fear about palliative care because of its, that euphemistic language, medical assistance in dying. Some people really are actually more afraid now to come to a hospice because they're afraid we are going to be doing euthanasia there and shortening their life. So it's really just intensified those old stigmas and fears about palliative care that we've worked so hard in the last 30 to 40 years to tell people understand that's not what we do. And then I'll just wrap up, and I know I've been talking for a long time. Thank you for your attention. This is, to me, one of the biggest difficulties with making death a medical treatment, and that there is no requirement for those treatments or supports to address the suffering and the underlying illness, even for a treatable condition. And so you as a doctor, like if you had a patient come to you, and I use two examples to help people understand this, who, let's say they had a first seizure. And that person was a long haul truck driver, and they didn't want to have the chance of another seizure because they're going to lose their driver's license and their livelihood. So they say, I've read about that deep brain stimulation. I want that to make sure I never have a seizure again. I know that sounds absurd, but kind of asking for death can also be a little absurd. And when would a doctor say, okay, sure, you're asking to be referred for deep brain stimulation, I'll contact the neurosurgeon and let's get that going for you. We don't do that because we follow evidence-based practice for standards of care. So we're going to try our usual, like, first I'm going to figure out what's going on, of course, but there's a evidence-based, low risk, high likelihood of making a difference to higher stakes procedures and surgeries and things that we follow in a graded fashion. But we don't do that with euthanasia. If someone says, I want to be dead, I would argue that's the highest stakes there are in life, to become dead. It's just considered like you would have that first line. You just need to know what other options are, but you can just have that if that's what you want. Like, it's just mind-boggling to me. I use the other example of osteoarthritis. So someone has a new diagnosis of osteoarthritis, been having some pain in their hip, they come to use the GP and they say, I just want my hip replaced. Like, I can't deal with this. Like, this is so painful. Just give me a new hip. Like, none of us would just, without having tried, basic conservative measures first, would say, oh, okay, sure, you can go see the orthopedic surgeon, we'll get that hip replaced. We wouldn't do that. We're going to try Tylenol, anti-inflammatories, and physical therapy, right? And you're going to go through those evidence-based progressions. So I just think that it completely undermines the standard of care in medicine, that there's no requirement to have tried any type of treatment for treatable conditions or follow any type of evidence-based practice, and that we have to participate in facilitating someone's death because a patient asks for it. So I can't provide my recommendation to a patient about what I feel is in their best interest because I'm accused of blocking access to MAiD if I do. So it's been very challenging. And there is this real difficulty now with, are we doing suicide prevention or are we helping people complete suicide? So there are patients who come in actively suicidal with all of the red flags you learn in medical school and residency for when someone is like, should be formed and admitted to hospital. But those patients, I have many examples, those patients are given the MAiD phone number to call it. I personally have called the psychiatry team for help. And in the past, this person would have been admitted and they said, here's the MAiD number, you have cancer, you don't have to do it yourself. So it's just very difficult. And I like to show this cartoon, which is actually developed by the disability community in Australia many years ago. But this is truly how the disability community in Canada are feeling. And they've been sharing this broadly on social media. And they believe that they've been given a fast track to assisted suicide and not, resources to help them live. But I think that actually applies to everyone in Canada, that the MAiD law applies to, not just persons with disabilities. But I think especially people on the margins who don't have what my colleague, Dr. Sanu Gain, calls a privileged autonomy. People who don't have a privileged autonomy to be able to have the resources they need to live are the ones who are made vulnerable by this legislation. And then finally, it really is changing society. This is an example of a couple who the wife had multiple sclerosis, the husband had metastatic renal cell cancer, and the wife decided that she just couldn't go on anymore with her multiple sclerosis, and she wanted to die. And so her daughter said to her, and this is all like in this CBC story, have you ever heard about medical assistance in dying? And so they asked the hospital team, and so they talked about it, and she thought that would be a good way for her to die. And then her husband was just devastated that she would die before him, because he had always thought he would die first because he has renal cell cancer. And so they actually decided to get euthanasia together because they couldn't bear to be apart. So, but the media glorified this story, what I think is very tragic. They glorified this story as the first couple in Prince Edward Island to get MAiD together. And it was this romanticization of this love story between these two people, that they loved each other so much they died together by euthanasia. So it's really been romanticized in medical journals as well, not just in the public media, as that this is the most beautiful death and the only way to die with dignity. And as I've said, perpetuates those myths and fears about what ordinary dying and death are. It's also causing a lot of division and conflict within families. Although patients are encouraged to talk to their families about it, many people don't want their families to know. And imagine when that gets extended to children, that they don't have to tell their families. And you would find out as a parent, I have 5 children aged 13 to 21, any one of those children, they're 21, but they still, the frontal lobes aren't fully developed, right? I just can't imagine. Can you imagine like finding out after that your child has been killed and you had no opportunity to intervene? And so there's a CBC, which is the equivalent of BBC, Canadian Broadcasting Company, Fifth Estate, which is a documentary series that came out last week, which interviewed families and their turmoil and distress about finding out either after their loved one got euthanasia or within the day or two before, and they couldn't intervene and stop it. And they knew that the reason that they were getting it was because they were depressed or lonely. So it's worth a watch. I'm sure we can send out the link because it's the families telling their stories firsthand. And it's very difficult to watch, but I think it's important. And we're not really talking about what about those bereaved families? Like, what is the impact on them and how are we supporting them? And I've talked about the need for safe spaces. But it's very difficult to declare yourself as a safe space or a safe position, because then you're seen as being anti-MAiD and trying to block MAiD. And so I know you talked a little bit about risk earlier, or going against the grain. Just the fact that I'm here talking to you today, and I've done other talks in the past, I absolutely will receive threats and be professionally, I do get professionally marginalized for speaking up about patient safety, because advocating for well-being and safety is seen as you being anti-euthanasia. And for me, it's not about whether this is right or wrong. It's about, can it ever be done safely? And I think the evidence from Canada is very clear, and Belgium and the Netherlands, that this cannot be done safely, because the safeguards get changed over time and the eligibility expands over time. And in the jurisdictions that have been doing this for a number of years, it's not the worried, wealthy, well-off, well-educated people who are kind of driving this ideology for a right to die and have that privileged autonomy, but it's the people who are vulnerable that don't have the resources to live and access the same type of healthcare and social supports that end up paying the price. And I think that that's unacceptable. So in conclusion, I just want to leave you that I think there's really a lack of accountability, lack of oversight and monitoring when you make this part of medicine, because it's left to medical practitioners to oversee their own practice, and the regulatory bodies have little oversight with that, and there's nothing in real time to prevent wrongful death. There's been a rapid progression of expanding eligibility and removal of safeguards, as I've shown. An increasing percentage of Canadians who, when faced with an illness or disability, are choosing to die because of inadequate social and healthcare supports. And I think it's really putting vulnerable people at risk. And death as a medical treatment is very problematic for an under-resourced and underfunded and undereducated healthcare system. People don't have good education in palliative care or understand what supports are out there for persons with disabilities and home care resources. And MAiD is often offered as, I think people are trying to be helpful, but because they don't know what else to do, but it's very problematic, and it's replacing care. Death practice is replacing care. It's called care, by the way, by the MAiD providers, that they say this is the most rewarding thing they've ever done. And it's cradle to grave care. But I think we should call it death practice. Because I worry that it's not really care, and it's not in keeping with medicine, in my opinion. The goal of medicine is to provide care and supports to help people achieve well-being, maintain well-being, improve function, and improve their health. It doesn't necessarily mean cure, but health is a holistic concept. And I don't think medical practice includes ending a person's life. And there's pressure for all healthcare professionals to facilitate it or provide it on site. So I'll just leave with this quote. One of my mentors, who's a bioethicist and pediatric hematologist at Dalhousie University: when euthanasia is legalized, doctors respond to cries of anguish and desires for death by initiating processes of eligibility rather than reassessment of all aspects of care. So death becomes the treatment. Thank you.
Leonie, thank you very much for, that was a tour de force, actually. I'm just left with this question in my head. How is it that we've come to this? I never ever did think it was part of a doctor's job to end life, and yet that seems to be what has arrived in Canada.